I'm Gabi, I'm a nursing student at Mount St. Joseph. I'll be doing a newborn assessment. I would do hand hygiene, and then I would check name and date of birth on the wristband. I would then place the baby in a warm environment in the radiant warmer. I would visually assess the baby. I would check its posture, flexion at the elbows, the hips, and the knees is normal. Posture tells us about the baby's muscle tones. Check body proportions and notice symmetry as baby moves. No marked jitterness, tremors, or seizures. And then check for gross abnormalities that are detectable at this point. I would then take the baby's temperature, and I would do the temporal temperature. So I'd go over the forehead, down to the ear. And then a normal temperature would be 97.7 to 99 degrees. And the patient doesn't appear to have any signs or symptoms of an infection. So then I would then listen to the heart and breath sounds as the baby is quiet. So I would warm up the stethoscope with my hands. And then I would place the stethoscope at the point of maximal impulse and palpate to find this area. And then I would check for rhythm and count respirations for a full minute. Normals would be 110 to 160. Then identify if there's any heart murmurs, and then strong pulse in the brachial and then both the femoral areas. And then I would visualize how the baby is breathing. So if the chest and abdomen are moving together in respirations, normal to see the abdomen moving more than the chest. And then I would count these for a full minute. Normal rate is 30 to 60 breaths per minute, and I would look for any signs of respiratory distress. I would then listen to breath sounds, warming up the stethoscope. I would start in the upper lobe areas and go under the arms, and I would compare each side. And the stethoscope placed on lateral portions of the chest for the best contact. An air exchange should be equal on each side, and I would be listening to any avitition breath sounds, like crackles.
Is how I interpreted it.
And then I would listen to any bowel signs. I would listen to these for 30 seconds each, starting at the right lower quadrant, going to the right upper quadrant, left upper quadrant, and left lower quadrant.
That, I got this.
I would look at the lips and mucous membrane for color. These mucous membranes should be pink. And then I would look at hands and feet and the rest of the body for color. I would assess the color of the hands and feet. If blue, there's poor peripheral circulation, which is not common to see in the first 24 hours of birth. And then it's uncommon to see babies that are blue all over, because this is going to mean inadequate oxygenation. So then I would assess the skin for normal, soft, smooth, with deep cracks in the abdomen. There's no apparent jaundice. Blood vessels may be faintly visible, which is normal. And we may see peeling skin, which is normal. Babies should be pink in color, and you may see birthmarks. So then I would assess for turgor, and I would do this by pinching and letting go of the side of the stomach, directly under the arms. They should immediately snap back, and seeing any molding or milling around the mouth is normal. And then blanched skin over the bony prominence in the eyes to assess for jaundice, and jaundice is abnormal. So we would then obtain some measurements. We would first weigh the baby, and then we would do occipital frontal circumference, which is measured just above the eyebrows. And then a normal is 32 to 37 centimeters, and then chest measurement is taken at the nipple area. And it's usually 2 to 3 centimeters smaller than the head, and an average is 30 to 35 centimeters. And then length is measured from the top of the head to the heel, and the leg should be fully extended. And this would be average of 48 to 52 centimeters. So I would then begin my head to toe assessment. So I would lift the baby's head and support it with one hand. I would palpate the fontanelles and suture lines with fingers. So I'd start in the middle and go out. Then you start where the hairline starts, middle of the forehead. It should be soft, flat, and firm. And then pulsations is considered normal. The anterior fontanelle, which is the top of the head, is larger than the posterior fontanelle, which is the back of the head. And then hair texture should be fine and silky. So you would assess facial features of the baby. This is done best when the baby is crying. For the eyes, you should notice placement of the eyes. Edema of the eyes is common. I would lift the baby's head, and then
same for the respiration rates.
I would use the pen light to assess
because they can have a regular respiration. Normal respiration for an infant
by going in and out.
30 to 60 beats per minute.
And the iris will be deep blue. The sclera is bluish white. I would check the pupils for response to light. Look for constriction of the pupil. Check to make sure light is in the same spot of both pupils, and there's no sign of jaundice, discharge, or hemorrhage. So for the ears, I would then evaluate placement, and I would draw an imaginary line from the outer campus to the outer canthus to the pinea. The pinea should be even or above this line. And then I would then check for any lesions in the front of the ears, and the pinea should be well curved and would feel around the ears. I would then pinch the upper and lower parts of the ear together and make sure it snapbacks immediately. I would check the hearing acuity by clapping to the baby each side and seeing if there's a response of like blinking or crying. So clap on one side, clap on the other. I would then start checking the nose, looking for symmetry, and then I would check for patency.
So now we're continuing our assessment of the skin. A normal term baby.
I would do this by closing one side of the baby's nose while making sure the mouth is closed and seeing if it's still breathing. And I would repeat this on the same side. I would then do, I'd put on new gloves to then assess the mouth.
The skin, assessing for skin turgor, just like we would in an adult. You can see different skin conditions, so like milia, lumbago, mottling, blanched skin.
I would then evaluate the rooting reflex, so I would stroke the teeth or touch the side of the mouth, and the baby should open her mouth or turn towards the side that's being stimulated. The tongue should be freely moving around, and I would put a finger in the mouth to evaluate the sucking reflex. I would make sure to palpate around the gums lines when doing this, and I would palpate hard and soft, palpate for integrity and intact. This may elicit a gag reflex. The mucous membrane and lips should be pink and moist. I would assess the oral cavity when the baby is crying. I would do this with a pen light. And I would look for hard, soft palates should be visibly intact. Uvula should be the midline moving symmetrically, and then you may see Epstein pearls on palate, which is small dots being shown. So I would then assess the neck. There should be short and creased with lots of skin folds, so I would separate the skin folds to visualize the skin. I would palpate the masses and swollen lymph glands all around the neck and lower jaw. I would turn the head from side to side to see full range of motion. I would check for trachea midline. I would then assess the chest. I would check for integrity of the clavicle, so it should be straight. Lump is present, there's going to be a fracture. So to evaluate the breast development, the areola should be full. A normal would be 5 to 10, and this would be done with the tape measure. And then breast engorgements is normal in boys and girls babies, and then symmetry of the nipples. I would then assess the abdomen, so it would be rounded due to relatively large sizes of internal organs, which is related to baby's size. The umbilical cord, it should be plump and pale yellow. At birth, there should be 2 arteries, are muscular and look small and tight. The umbilical vein is large in size and has pellucid walls. Vessels are counted in assessment. There's a lack of artery, which can mean a defect, and then there should be a total of 3 holes in the umbilical cord. So you would palpate and move. When doing the abdomen, I would palpate and move in a clockwise direction through the 4 quadrants. I would start with light, and I would feel for any abdominal tone and presence of masses, and then I would go deeper, which I can feel the baby's liver border, and there may be able to feel tip of spleen at the right costal margin, and then kidneys may be felt if the baby is well relaxed. I would then assess the femoral pulses and check for character and quality of these pulses, and then I would do the same on the brachial pulses. I would then move to the assessing of the perineal areas. So for a boy, I would assess the location of the urinary meatus. The scrotum is usually dark pink in Caucasian and deep brown in dark skinned babies. There's, so I put my gloves on.
Tongue should freely move around the mouth. At that point, you can stick your finger in the mouth and evaluate the sucking reflex. You should suck
I would then palpate both testes on each side and start at the external inguinal ring and move down to the scrotum. It should be descended by 40 weeks. I would assess the cremastric reflex, which is by lightly touching the rear inner thigh to the top, and the testes should be then elevated. So the importance is to note when a baby first voids. This is expected by 24 hours of age, and it sometimes can occur during delivery. I would then, if this was a female, I would assess the external genitalia. I would spread the labia and exert gentle downward traction, assess the urethra and vaginal. And you may see white or colored tinged mucus discharge, but this is normal. I would then assess the butt, so it would be checking the anal patency. Confirmation occurs with first bowel movement. This is expected within 24 to 48 hours after birth. The baby has pooped 1 stool, thick yellow brown in color, and then you will continue to monitor. So then I would check the anal reflex, and this is stroking skin next to the rectum.
Symmetry of the nipples, make sure they're the same height. Moving down to the abdomen.
I would then assess the hips, which is evaluating if knees are equal at height by bending them up, which is normal. I would check stability of the hips. Thumb should be at the baby's inner thighs while knees are pushed in, and then I would move hips around inward thighs. Should not be dislocated or any clicking. I would then turn the baby on its stomach. This would be for tummy time, and I'd be able to check some things. So I would look for symmetry of the scapula, look at the back of the head for any signs of trauma, and look at the creases in the neck. I would then assess the spine for any visual integrity and straight and intact. I would palpate presence of the vertebrae. Tufting of the skin at the sacral area is abnormal. And I would look at dimples at base of spine and be sure that they are closed. I would assess the gluteal folds and thigh folds, which they should look alike on each side. And if there's symmetrical, this could mean there's a hip dislocation. I would then heat up my stethoscope, and I would listen to breast sounds again.
At this point, it's important to note that it should always be
I would place stethoscope below the scapula and listen from side to side.
In a female, like we have here, you want to assess the external genitalia. In a term baby, the labia majora should cover the
I would then do the trunk incurvation reflex, which is holding the stomach, lift the baby up, stomach down, lightly touch the scapula to top of the butt on each side, and the baby should move towards side of finger that is being touched. I would then do the stepping reflex, so I would place the baby's foot in contact with a firm surface, and this foot that's on the contact surface should flex,
If you stroke
and then
next
this one will
to
flex and then
the rectum,
extend.
you should see retraction, checking the anal
And then the
reflex.
general
At this point, we'll
muscle
move
tone and
into
symmetry of the baby moves around on their
Change the
own.
weight of the
So I would
hips.
then look at the upper extremities. I would feel shapes and outlines of the bones in each extremity. I would palpate. All joints should have full range of motion, but you may need to unfold the fingers to be able to count the joints. I would look at the creases in the palms. I would check the palmar grasp reflex, so the baby would then hold onto the finger and be able to lift hand up. The nails should reach the tips of the fingers. And then looking at the lower extremities, I would then feel and shape the outlines of the bones. I would check for full range of motion. I would check for planar grasp reflex. I'd put one finger at the upper part, bottom of the big toe, bottom of the foot, and then toes should then surround the finger. I would then do the out and ski reflex. I would stroke up the foot from the heel to the little toe, which would then go across the ball foot to the big toe. The big toe would flex while other toes extend. I would then assess the crease on the bottom of the foot. Closer the creases are to the heel, the more mature the baby is. I would then do the moral starter reflex, and I would hold the baby in arms, and I would suddenly drop the baby, and I would look for specifically at symmetry of the arms. Index of the fingers and thumbs should form C shapes. The baby is 1 day old and has 1 wet diaper so far, which is to be expected. The urine looked brisk, dusk in color. Intake and output are being monitored by weighing the wet diapers, subtracted by dry diaper weight to wet diaper weight to obtain the output, and then we will continue to monitor. So I would then leave the baby, make sure everything is safe, and I would end my assessment. Perform hand hygiene.